Good morning, everyone. My name is Kleir Nyacinth Castillo. I am a student nurse from Nueva Ecija University of Science and Technology. I am here to perform the umbilical catheterization via bird box procedure. For the assessment, a timeout should be performed with particular attention to assure that the correct patient is identified and to assess for any contraindication to the procedure. The procedure should take place inside the radiant warmer to avoid the environmental exposure to the infant. For the planning, equipment as listed below should be obtained and inspected. Appropriate lab work, if available, requires review. Written consent is necessary from the patient or guardian of the neonate after the discussion of the risk, benefits, and alternative of this procedure if not performing the procedure emergently. Then, flush the catheter with heparinized saline to ensure that there is no air present in the catheter and to prevent the clotting. Then, attach a 3-way stopcock to the catheter. Then, for the equipment, we have the radiant warmer, sterile gown, sterile gloves, cap and mask, sterile drapes, bactericidal solution, umbilical tape, scissor, scalpel, iris forceps, non-tooth forceps, umbilical vein catheter, 3-way stopcock, IV tubing, needle driver, 3-0 silk suture, sterile saline flush. And for the catheter sizes, we have the preterm, 3.5 French, and for the term, we have 5 French. For the implementation, the first thing you're going to do is to put the sterile attire. Number 2, the umbilical stamp should undergo preparation with the bactericidal solution and a loop of umbilical tape placed at the junction of the skin and the umbilical stamp. Then, number 3, drape the procedural field with sterile drape. Grasp the umbilical stamp with non-tooth forceps and apply upward traction to strengthen the umbilical stamp. Number 4, take the scalpel and make a transverse cut completely through the umbilical stamp, 1 to 2 cm from the skin to expose the non-dried umbilical cord to aid in anatomical identification and cannulation of the umbilical. Then, identify the 2 umbilical arteries by their thicker walls and the umbilical vein by its position at 12 o'clock and its larger thin-walled appearance. Number 5, umbilical tape may be tightened to control bleeding if present. Gently use the iris forceps to cannulate and dilate the umbilical vein and to clear any thrombus present in the umbilical vein. The number 6, grasp the umbilical vein catheter with the iris forceps and gently introduce the catheter into the umbilical vein. If the clinician meets resistance, loosen the umbilical tape and attempt to advance the catheter again with gentle pressure. Number 7, if the significant resistance is still present, after loosening the umbilical tape, abandon the procedure and seek an alternative method of intravenous access. Then, if the line placement is for emergency access, advance the catheter 1 to 2 cm past the point of initial blood return in the catheter, which is usually 4 to 5 cm in full term. Then, if the line placement is for more long-term access, the line should be advanced into the inferior vena cava just beneath the right atrium, which is usually 10 to 12 cm in a full-term neonate. Number 8, secure the catheter using the suture through the cord. Number 9, after suturing the catheter in place, use tape to create the tape bridge between the abdomen and the catheter for the extra protection against displacement. Number 10, place a transparent dressing over the umbilical stump and umbilical venous catheter.